Thank you for joining us on this Arthrex Bunionectomy Series. I'm Dr. Joseph Park, and in this episode, we will be addressing common questions and objections around minimally invasive bunion correction. For more specifics on the technique and general background info, please view some of our other episodes. I'm joined here today by Dr. Noman Siddiqui from Baltimore, Maryland, Dr. Tom Harris from Los Angeles, California, and Dr. Jim McWilliam from White Plains, New York. Gentlemen, thank you for being here today. My first question is, with these osteotomies, and you see them radiographically, postoperatively, do they really heal? Dr. Siddiqui?
Well, they absolutely heal. I mean, one of the things that convinced me to do this procedure was the amount of bone that healed and the power of the correction at the same time. And in my practice alone, we have a 99+% success rate with this healing. We have had one non-union, and this is over 12 years. So it's been a long time, and I think in that sense, to your question, they absolutely heal.
Dr. Harris, for the surgeon who's concerned about seeing that X-ray and seeing the capital fragment shift over, how would you reassure them that this would heal?
We've got great research and literature to support it. I think often the people who are asking that questions are other surgeons rather than the patients. I think telling the patient ahead of time about what the X-ray is going to look like post-operatively and kind of letting them know that that capital head's going to shift over a lot. There'll be a big gap between the two bones. But within 6, if not 8 weeks, you'll see a wisp of bone that eventually turns into a nice callus by 12 to 14 weeks. So I think a lot of the naysayers or the doubters are often other surgeons. But I think since we have great fixation now, it's really the main reason why these heal so well.
And how do you explain that to the patients, Dr. McWilliam?
Usually I illustrate it with other x-rays from prior patients. So I'll say, here's the way your shift is going to look. And by creating kind of a crooked bone, we've created a straight toe and a straight medial column or a straight first ray. And then I'll show them subsequent x-rays, both of the clinical correction. So I take lots of pictures of patients to use as illustrations because patients really find that very helpful. The foot looked like this before, it looks like this after. The x-rays look like this before. You have these screws in, everybody's afraid of screws and leaving screws in, but then when I show them after what it looks like, they're very satisfied that they're gonna get a good outcome.
We certainly see this bone healing and filling in, almost like a stress fracture of the metatarsal. See this bone callus forming and filling in there. So I think that's a great tip to show other patients, other postoperative x-rays.
Well, I think rather than calling it callus, this is primary bone healing. So it's in a very defined area that's very consistent from patient to patient. It's not the abundant callus you see with an unstable metatarsal stress fracture. This is a very stable construct that, because of elevation of the periosteum laterally, is going to lead to primary bone healing within this limited scope.
Let's talk about complications. Dr. Siddiqui, have you seen any complications?
Yeah, I think, I alluded to that in the time I've been doing this, I've had one non-union. So that is an obvious complication. But, if you really look at it, the patient was a diabetic, non-compliant smoker. So I think it has shown me, and then he's still healed in the sense that he has a hypertrophic non-union. He wears a regular shoe and is able to function. So I think it's all relative. Now, the most other common complication, but I call it a problem, which it means is it bothers the patient, but doesn't impact their final outcome, is the hardware irritation from the previous generation, which has now pretty much been eliminated because of the beveled screws that we're using. So that's the other issue. The other, so to speak, common complication would be infection. And I think that's what we saw in the previous generations, that we had some skin and soft tissue infections when we were using the pin technique. Whereas now with the screws, there is not that case. That's not been the case. I've not had that, especially with the beveled screws.
Dr. Harris, any complications you've come across?
Well, I think one is nerve, and I think it's common after the surgery for patients to get a temporary, and I'll emphasize temporary, paresthesias in that dorsal medial cutaneous nerve region. I thought at times that I've wrapped up the nerve or that I've completely cut it, but within 3 to 6 months, that sensation comes back. So it's almost always been a temporary phenomenon. So that's good knowing going into this that you're not going to have any permanent nerve damage from this type procedure. I think non-unions are extremely rare. Malunions can happen. It's important as you're going through. Even a few weeks ago, I had a case where I placed the 2 screws and I just had some weird crepitus in dorsiflexion. It wasn't moving up as much as I thought it should. I got a really good lateral, could see I'd plantar flexed the head down, and I was able to back out the screws and the wires, reduce the head, place the K-wires and re-drill, then place the screws, and then it moves smoothly. And that was an intraoperative thing that I may not have discovered or may have blown off a couple years ago, but those sort of things can still happen. So it's good to be vigilant intraoperatively as well. But the nerve usually resolves. Malunions are typically a technical problem, and non-unions are exceedingly rare.
Dr. Siddiqui, can you speak anything to that neuralgia along the medial aspect?
Yeah, we noticed two things. One, we started asking our patients after having a large bunion if they were having numbness along that dorsal medial surface, and many of them were already pretty numb. So then when we kind of took those patients out, we did find that the few patients that had the issue that Dr. Harris is talking about, on average, 8 months later, the symptoms were resolving. So I think it's exactly what he's saying. A few months later, it does seem to resolve in the small patients that it does occur.
So the initial deformity was causing that nerve, those nerve symptoms, and were resolved after the reduction and correction.
Yeah, and I think that's why it's part of our preoperative workup to make sure we document if they do have that in place.
Dr. McWilliam, any other experiences with complications?
I think a couple of things. One is it's really important to document the status of the nerve, both to know what's going on and medical legally. I think you protect yourself. So if the patient had preoperative nerve symptoms, postoperatively, they pre-existed. The other thing is the vast majority of the complications I see are my error, technical errors. And I think it's really important that we pay close attention to the technique. And I think having the availability of the shifter and the trajectory guide is going to decrease that rate of complications. But overall complication rate compared to other bunion procedures is much lower.
Yes, correct. And I agree with that, where the technique is much more reproducible. So that's taken out a lot of the human error and made things a lot better, a lot more effective here.
One thing I've really noticed is the lack of stiffness in these MIS patients. And I've said it before, but having the open chevron whose x-rays look perfect, and then you actually see the patient and they got a 20 or 30 degree arc and they're pretty miserable, versus these patients where the x-rays can look a little crazy at first but get better over time, and their motion from day one is great.
And their clinical appearance in the face of these crazy x-rays is perfect.
Exactly. So it's something to keep in mind. The lack of stiffness is huge for patients, and it made a big difference that won't necessarily translate to x-rays.
The funny thing is we keep calling it crazy x-rays, but it used to be, so for me it's been normal because I've been doing this for so long.
Right.
But if you look at the other open procedures, scarves, aggressive chevrons, closing base wedges, to me those look crazy.
Sure.
Whereas once you get your eyes set on doing a mechanical realignment, I think it becomes normal, like, oh, this is how it should be. And whether it's your x-ray, my x-ray, your x-ray, all our x-rays relatively look the same. So is it crazy that they look the same? That's the question, right? I think it's consistency.
Yeah, absolutely. I've been very happy with it.
Yeah, it certainly becomes more the norm as you get used to that as well. And I think it's interesting how the patients, obviously, they've had no prior exposure, right, to looking at these types of x-rays. And they can, from time to time, become concerned, right, when they first see the first couple of postoperative x-rays. And then we have to reassure them that this will heal appropriately. For me personally, again, not necessarily complications, but issues maybe were prominent hardware and removal thereafter was largely alleviated after utilization of the beveled screws. So even with the hardware removal or even a little shave down of a bump or prominence can often be done in the office. That's what I will do from time to time as well. We all feel bad when the patient has to have surgery again. So whether that's in the hospital setting or in the office setting, that can be done. How would you respond to the belief that the source of the deformity is proximal and therefore the solution should follow? Dr. McWilliam.
I think it goes back to the cora and how you're going to correct your malalignment. So if the source is proximal, you'd have to go pretty far proximal to make your correction in the cora. So if your cora is like by the talus, then you'd have to do an opening wedge osteotomy, the navicular or something to correct it, which isn't going to happen. Because the cora is more proximal and our correction area is far from that, then you're going to get this obligatory translation. So you're going to still get a great correction of the mechanical axis with a more distal osteotomy. And I would argue with you that you're going to get a better correction because you have more capability of translating distally than you do proximally.
I agree with that. I think the mechanical access is the key here, and repairing along that mechanical axis. To speak to that, Dr. Harris, how has your practice changed as far as performing a lapidus or proximal procedure versus distal?
Well, I think I've kind of had a long history of doing bunions, and I started with proximal opening wedge, kind of shifted to more lapiduses, and then kind of pushed the limits of the distal chevrons open. So that was a kind of natural transition to the MIS. But in general, my number of lapiduses have gone way down. I've never been a huge proponent personally of that surgery. They say it's a non-essential joint, but I always think in a younger patient, if you can preserve it, so much the better. And I like the aspect of having the transverse cut and the rotational correction, which I think is huge, and what I couldn't really do too well with my long-armed chevrons. So I really like that part about it, and that really got me into doing these. So I'm doing less and less lapiduses. There are some that come in with arthritis in there, maybe some that have the true tried and true instability in that joint that probably best served with those, or the really huge IMAs that maybe be better as well. But in general, the number of lapiduses I've been doing has gone down.
Dr. Siddiqui, when's the last time you did a lapidus?
Yeah, it's been 7 years for me to do a lapidus, so it's been a long time. I just don't find any need for it. I think the lapidus procedure, though a good procedure, and if somebody wants to do it, they should do it if for the right indication. But that being said, for me, when a patient is asking me, what would I do for my family member? What am I going to do on myself? I'm going to do a distal bunion via an MIS method because I like to fix the problem where I see it. The bunion and the bump is right there. If I can do the same thing that I can get from a more aggressive procedure, yet allow my patient to walk a lot faster, get in sneakers faster, and potentially obviate the needs of a younger person getting a TMT fusion, I think it's worth doing. And that's why in the beginning I started doing it on everybody, so I could sit one day at a panel like this with really smart people like you guys and just say, hey, you could do it on everyone.
Let's say you have a patient who comes in to your office and requests a lapidus procedure, a 3D correction procedure. How would you guide them along? How would you respond to that?
Sure. I tell them if they're really specifically bent on doing that procedure, I'm not their surgeon. Because I have done that procedure before, and now I have transitioned my practice. MIS practice has, quadrupled or whatever in town, and now people just come to me specifically for this procedure.
Yeah, you're essentially doing the 3D correction like you mentioned, just distally.
Exactly, yeah. And Dr. Harris, have you tried any of the other newer fusion systems?
Not so much. I've been pretty happy with the MIS system. I do think there's still a role, definitely for an MTP fusion. There are those who have arthritic changes and crepitus and pain at rest, even with the bunion, and I think those do much better with an MTP fusion. And I do think there's a role for a lapidus as well, but it's just gone way down in my hands with the advent of the MIS bunion.
Dr. McWilliam, any experience with other systems?
Yeah, I've used other MIS systems, and I think the Arthrex system is superior because of the trajectory guide, the shifter, and the non-compressive screws with a large cannula that we alluded to in the prior discussion. I've tried other instrumented fusion systems, and I've found them to be not necessary to gain the appropriate correction that you'd want with a lapidus procedure. I think that the Arthrex plantar lapidus plate provides a much more biomechanically sound sort of platform for fusion of the first tarsal-metatarsal joint that allows for early weight bearing. Now, I delay the weight bearing a little bit, or I protect them a little bit longer because of soft tissue concerns. But I think that a lot of the focus that we have now on the lapidus procedure is kind of an industry-driven way of branding a procedure that's been around since 1937. So a company decided they wanted to make this their flagship. They gave it a nice name. And now it's become sort of the Kleenex of bunion procedures, where if you ask for a Kleenex and I offer you a tissue, you're not going to object. Whereas if you ask for a lapidoplasty, but I offer you any other lapidus technique, you're not going to know the difference. And I think the advantage of the MIS procedure, as we describe it, is that you get all of the components of the correction. You get correction of the valgus, you get rotational correction of the metatarsal, you avoid dorsal and plantar translation or angulation through a smaller incision, through very rigid fixation that allows for unfettered immediate weight bearing and a much lower rate of complication than any other type of proximal fusion or lapidus procedure.
I found in general, the less I do, the better the patient does. So what will allow me to do what needs to be done and not more than that. And this is the system for me that's been the most
less
beneficial.
is more, 100%.
Exactly. So let's talk about post-op protocol and what do you utilize, a shoe or a boot? When do you start weight bearing? Activities, at what point, physical therapy, things like that. And we'll start with Dr. Siddiqui.
I have been generally very aggressive with my post-op protocol. It was always weight bearing right away in a flat post-op shoe. I thought that was very important for the stability of the osteotomy. Now I have transitioned to sneakers with a carbon fiber insert at 2 weeks. And I typically let them increase a range of motion activities and impact-based activities based on two factors. One, if there's signs of no pain at the osteotomy site, which occurs around 8 weeks. So if they're not having pain at the osteotomy site, I know that the radiographic findings are going to lag by a few weeks. So I encourage them to do more activity at that point. So it's a very aggressive, robust protocol, and the limiting factor still becomes edema. So I'm aggressive with edema control with either compression socks and anything else. But the biggest part of my practice that's been beneficial for me postoperatively is the very minimal use of narcotics. I think on average, and we're in the process of getting this data, most patients are using it for no more than a couple days, which is huge.
And that's in addition to any anti-inflammatories?
No, I still, it's multimodal therapy. I do acetaminophen, 1,000 milligrams every 8 hours. I give them some form of anti-inflammatory as well, once or twice a day. And if needed for any kind of neuralgia-based symptoms at night, I'll kind of prescribe either a gabapentin or what have you. But it's very directed on minimizing the use of narcotics, and most, if not a majority of the patients, are not using narcotics beyond 48 hours.
Do you find any benefits to having patients weight bear as soon as possible as far as bone healing?
I think absolutely, because we're relying on stimulating the ground reactive forces to create callus. And I know Dr. McWilliam alluded to it being primary healing, but I think it starts that process early along the plane. And that's why I think weight bearing is important, because also range of motion. You prevent the stiffness at the joint. And you talked about that, Dr. Harris, that your patients are significantly better. And that's what I've noticed as well.
Dr. Harris?
Yeah, so post-op shoe from day one. There are some older patients that may feel a little more comfortable in a short boot, but typically it's a post-op shoe. I'd say heel weight bearing. Basically, weight bearing is tolerated that first week. We fight against the swelling like we would with any sort of forefoot procedure. So I'd love to get patients in shoes by 3 to 4 weeks. That doesn't always happen, but typically by 6 weeks, they're in flats or tennis shoes. Physical therapy probably happens 60, 70% of the time. Some patients are doing so well they don't need it or want it. I use absorbable sutures now, so we don't have to take those out. So those are just 4L monochromals. Those seem to kind of fall out in about 2 to 3 weeks, but overall pretty fast recovery. And I think the swelling, they still have a tendency to swell, as any forefoot procedure does, but I think you can combat that, and I think the swelling is less than an open procedure for sure.
I think we are generally seeing decreased need for physical therapy, because prior to this type of procedure, it was for the stiffness of the joint to get the range of motion. And with this procedure, we're not even touching the joint, and therefore minimizing any kind of scar tissue buildup in that area there. Certainly still helpful for ambulation and gait training, but I can concur with what you're saying there as far as physical therapy. Dr. McWilliam?
So I've become much more aggressive, mostly at Nomon's behest. So I try to get them into sneakers at 2 weeks. I do make them do a lot of compressive therapy before, so I make them wrap their foot in Coban for the first 2 weeks. But how do we treat edema? How do we treat swelling? It's elevation or compression, and I don't think there's a better compressive device than a closed-toed shoe. So I try to get them into a comfortable sneaker as soon as possible. And I tell them it may be uncomfortable. It's probably not going to be tremendously painful. But if it's too uncomfortable, then yeah, go back to your post-op shoe or your cam walker. But I find the more they maintain compression early, the sooner the edema and swelling will go away. So I'm a big advocate of closed-toed shoes as soon as possible, which is usually about 1 or 2 weeks. I also use a carbon fiber insert to sort of replicate a stiff sole.
Exactly. So for myself, it's the first 2 weeks of heel weight bearing in their surgical shoe. After that, enclosed shoe or sandals, whatever. And typically at that 2-week mark, the sutures come out, and then the patient's able to wear an enclosed shoe for the first portion of the day until about lunchtime, and then the swelling will be a little too prominent and built up, and then they'll switch to a sandal. At 1 month, I tell patients to try to do some stationary machines. So elliptical, stationary bike, that's when typically physical therapy will come into play. I like to tell patients that last 10% is where patients differ as far as getting back to full activity. So it can be anywhere from 8 weeks to up to 10 to 12 weeks to get back to that point there. In closing, these are some questions that we hear from people diving into MIS. Please be sure to watch some of our other videos to learn more about the Arthrex bunionectomy. Thank you.